Hello, this is a very small presentation on endodontic surgery. This topic will be covered in two parts. In part 1, we will just see introduction, classification, indications, contraindications, pre-surgical phase, differences between traditional microsurgery, problems with traditional surgery, the triad of microsurgery, and conclusion. Now, what is endodontical surgical procedure? Surgical procedures performed to remove the causative agents of radicular and periradicular disease and to restore these tissues to functional health. Now, the main objective of doing such an endodontical surgical procedure or an apical surgery is to surgically maintain a tooth that has an endodontic lesion which cannot be resolved by conventional endodontic retreatment. According to Grossman, these endodontical surgical procedures can be classified as root resection, orthograde filling during root resection and retrograde filling, root resection and retrograde filling following orthograde filling. According to Engel, this is a major classification. These procedures can be classified as surgical drainage, which involves incision drainage or cortical trephination. Periradicular surgery will include curettage, biopsy, root end resection, root end preparation and filling, corrective surgery, which includes perforation repair. Perforation can be mechanical in origin or resorptive, root resection and hemisection. Replacement surgery and implant surgery are other aspects of this classification. Wayne and Walton and Torregiban have also put forth a classification for these endodontic surgical procedures, and this is as the slide would depict. According to Kim, endodontical surgery is again classified as apical surgery, apicoectomy and retrograde filling, periradicular surgery, correction of procedural errors, management of root fractures, intentional extrusion, replantation, transplantation, hemisection and root amputation. Now this is a classification for case selection for endosurgery. It was given by Cohens and Burns, and according to this classification, class A is a condition wherein there is no periapical lesion, no pocket and the tooth is symptomatic. In class B, small periapical lesion and no pocket, and in class C there is a large periapical lesion with no pocket. So these are cases for microsurgical procedures. Class D again involves, it's similar to class C, but it has a presence of a periodontal pocket. And in class E, there is periapical lesion. It's proper endoperiodontal communication and there is no root fracture. Whereas in class F, there is an apical lesion and there is complete denudation of buccal plane. So Cohen and Burns classification is basically a classification that help you select cases for endosurgery. Now, why endosurgery? Why not just the normal root canal or re-root canal procedure? We all know that the success of root canal treatments is very high. It is as high as 53 to 98%. But there are conditions like true cyst and pocket cysts which do not heal even after re-root canal procedures. So these are the conditions which require surgical intervention to remove the pathology. Now, periapical cysts again are true cysts and pocket cysts. In case of a true cyst, there is a requirement of surgical intervention, whereas in pocket cysts can still heal with endodontic therapy. Now, what are the indications for endosurgery? When there is a necessity for drainage, when you have a condition where you have to establish drainage and for pain relief, then that becomes a indication for endosurgery. Failed retreatment case, that is also one other indication for endosurgery. When there is a complex root canal system which cannot be cleaned through normal, where BMP cannot be initiated successfully, then we do endosurgery. When there are anatomical issues like calcified canals, C-shaped canals, sharp angle bifurcations, pulp stones and calcifications. Iatrogenic issues, non-surgical treatment will be successful or is difficult. So those are other conditions which require endosurgical intervention. Now when the surgeon requires the tissue specimen to identify the pathology, then in case of biopsy, an explorative surgery is performed. View et al. Has has given this, where extra-radicular infection remaining in inaccessible areas, dentinal tubules, true radicular cysts, and foreign body reactions. And according to Kim, tooth has acceptable endodontics and has a new post-in-core restoration but a persistent and enlarging periapical lesion. Now, what are the contraindications for endosurgery? Retreatment is possible, or when there's poor endodontics or periodontal issues, then we do not consider endosurgery. In case of neurovascular structures being present under the tooth structure, lack of surgical access, when the tooth has no function in the oral cavity, systematic diseases, and the surgeon's skill and ability is under question, then in those conditions endosurgery is contraindicated. Pre-surgical, before we perform an endosurgical procedure, patient is always subjected to a pre-surgical phase. Now, what is this pre-surgical phase? Basically, this phase involves diagnosis of an oral examination, a radiographic evaluation, medical evaluation, stress management, and pre-medication. The oral evaluation basically requires assessment of the chief complaint. GP tracing procedure can be done, and also vertical root fractures have to be eliminated during this phase of oral evaluation. Radiographic evaluation includes identification of apical curvatures, length of roots, periradicular pathosis, root resorption, proximity of roots to inferior alveolar canal, and mental foramen. Now, CBCT is required. Advanced radiographic methods have to be initiated for proper assessment. So, CBCT will show significantly more lesions, so it is preferred for endosurgery. Now, before starting endosurgery, we will have to prescribe a set of antibiotics. It goes by the standard regimen: amoxicillin 2 grams pre-op 1 hour, and clindamycin 600 mg pre-op 1 hour, cephalexin 2 grams, azithromycin 500 mg. Now, when we talk about surgery, there is traditional endosurgery and there is microsurgery. Microsurgery basically involves the use of microscope for assisting a surgical procedure. Now, what is the differences between traditional and microsurgery? The osteotomy site in a traditional endosurgery is approximately 8 to 10 mm, whereas in microsurgery it is 3 to 4 mm. The bevel angle degree is about 45 degree in traditional surgery, whereas it is only 0 to 10 degrees in microsurgery. Inspection of resected root surface cannot be done in traditional surgery, whereas it is always possible to inspect the resected root surface in microsurgery. Isthmus identification and treatment is impossible in traditional, whereas it is always possible in microsurgery. Root end preparation is seldom inside the canal in traditional, whereas it is always within the canal in microsurgery. Root end preparation involves a burr in traditional surgery, whereas you can use ultrasonic tips in microsurgery. Root end filling material preferred is amalgam in traditional and MTA in microsurgery. Sutures as fine as 5 to 6 monofilaments can be used. 6 monofilament can be used in microsurgery. Suture removal can be done in 2 to 3 days post-op in microsurgeries, whereas it requires 7 days post-op for traditional surgery. And the healing success, which is a very important part of endossurgery, is very high with microsurgery. It's close to 96.8%, whereas it's only 90% in traditional endosurgery. Now, what are the problems with traditional surgery? Poor visibility, unsuitable surgical instruments, failure to locate, clean and fill the anatomical irregularities, post-operative complications, and failure of the treatment are problems with traditional surgery. Microsurgery always involves a triad, and this triad basically is comprised of magnification, illumination, and instruments. In magnification, it is important to note that you can set the microscope settings to a low magnification, mid-range magnification, high magnification. In the low magnification, the magnification is close to 4x and 8x. In this magnification, orientation is possible, inspection of surgical site can be done, and in the mid-range magnification is where most of the surgical procedures are performed, and the removal of granulation tissue is possible in this mid-range magnification. High magnification involves magnification as high as 26x, and in this magnification it is possible to inspect the resected root surface and root end filling and observation of anatomical details. The instruments used for endosurgery can be classified as Group 1, Group 2, Group 3, Group 4, Group 5, Group 6, Group 7, Group 8, Group 9, Group 10 and others. Group 1 involves examination instruments, Group 2 involves incision elevation instruments, 3 involves curettage instruments, 4 inspection instruments, 5 retrofilling instruments, 6 miscellaneous instruments and so on. Now examination instruments basically involve mouth mirror, periodontal probe, endo explorer, micro explorer tip, and these are very fine instruments modified for microsurgery. Now incision instruments involve a 15C blade, which is the ideal blade. You can also use a micro blade, especially if you want to incise in the tight interproximal space. The soft tissue elevators used in endosurgery involves Moll's elevator and periosteal elevator number 9. Tissue retractors used for endosurgery involve Austin's retractor, Minnesota retractor and Wader's retractor. Kim track retractors are also other retractors used for endosurgery. Kim pecora retractors can also be used for retraction of tissue in endosurgery. Now osteotomy instruments, a straight handpiece is preferred. Microhead handpieces are also used for the osteotomy procedure. Curettage instruments basically involve periodontal curettes, surgical curettes, mini endodontic curettes. Inspection instruments, these are the inspection instruments. Other miscellaneous instruments required include the retrofilling carrier and retrofilling pluggers. Ultrasonic tips basically are KIS tips. KIS tip 1 is shown here in the slide. These tips are basically coated with zirconium nitride and they have an irrigation port near the tip. KIS 1 is used for mandibular anteriors, KIS 2 is used in maxillary anteriors, 3 is used in maxillary posteriors and 4 is used in mandibular, 5 and 6 are used in mandibular posterior. These are micropluggers which are used in endosurgery. The suturing instruments basically involves a needle holder and tissue forceps. Suturing instruments also will require Castroviejo needle holder and Lashl's micro scissors. Miscellaneous instruments, other miscellaneous instruments include the ball burnisher, bone file and bone grounger. Now in part 1 we saw the armamentarium and the classification of endosurgery, and there was a classification by Cohen and Burns which helps us with case selection for endosurgery. In part 2 we will look into flap designs and endosurgical procedures. Thank you.